will talk about the role of imaging in diagnosis and the staging of lung cancer. And you will know that the intimate relation between cancer and the smoking, and also you are familiar by the histologic types of different lung cancers, but I would emphasize the role of imaging. Number one is to categorize the primary pathology. Number two is to assess the local relationship between the tumor and the intrathoracic structures, and also to assess for the possibility of distant metastatic disease. In the old days, before the era of MRI and CT, we used to diagnose lung cancer from the plain X-ray, and we have certain imaging or radiographic criteria, which include the presence of a peripheral nodule with a speculated margin, the enlarged dense hilar shadow, the presence of pulmonary mass in an adult, and the presence of a central lesion with ipsilateral diaphragmatic elevation indicating phrenic nerve paralysis. Also, the presence of consolidation collapse of a lobe secondary to bronchial obstruction by a central lesion, the detection of malignant cells in a pleural effusion, and the S sign of Golden. This is an example of a nodule with somewhat speculated margin or lobulated margin in the left lung field, and this is an example of a pulmonary mass. Of course, these want to be evaluated after that by CT, as I will mention. Here you see left lower lobe collapse, and there is a central mass with elevation of the ipsilateral diaphragm. And this is an X-ray of an enlarged dense hilar shadow with ipsilateral elevation of the diaphragm, and the CT showed a cavitating tumor with a thick margin and irregular inner wall. Then we have the S sign of Golden, which indicates the presence of a central bronchogenic carcinoma with secondary collapse of the related lobe. And this is the appearance of the S sign as quoted from the literature. Of course, the use of CT has much more improved the detection and the characterization of pulmonary nodules in particular, and we used to diagnose the lung cancer based on the presence of a nodule with a speculated margin like this, and we can easily differentiate this from the benign nodules, which have a smooth margin and may contain calcium. This is a good example of a peripheral bronchogenic carcinoma with typical speculation of the margin and the old sign of the presence of pleural tails as well. And here there is also an example of a speculated nodule in the periphery of the right lung. And we usually try to differentiate these nodules in particular from the pulmonary arteriovenous malformation, because one of the next steps for evaluation of the nodule is to have a biopsy from this, and we should exclude for sure that this nodule does not represent a pulmonary vascular malformation. An AVM is easily diagnosed by the presence of a vascular pedicle, which appears as two cords, the feeding artery and the draining vein going from the lesion to the hilum. Then a mass in the lung in an adult should be considered as bronchogenic carcinoma until proved otherwise. Whatever this mass has a speculated margin or an even smooth margin, also if it is containing calcium or not, we should consider this as bronchogenic carcinoma until proved otherwise. And this is a CT scan mediastinal window and lung window of a lung cancer in the right upper lobe with this speculation of the margin. And the incidence of calcium in the bronchogenic carcinoma is well known. It ranges from 7 to about 14%. And you may see calcium in the mass, but usually you do not see calcium in the nodule. Then bronchogenic carcinoma can also cavitate, leading to a cavity with characteristic thick margin and irregular inner wall. And in this case, we see a lesion which is located in the apex of the left upper lobe. It has a somewhat lobulated margin, and this is the follow-up after 3 months. The bronchogenic carcinoma has developed the central cavitation. Then, in order to diagnose a cavity as a malignant, we should have a thick margin of the cavity and irregularity of the inner wall. Then inside the cavity there may be only air or maybe a mass representing the shreds of the tumor before being expectorated by the patient. Then the presence of a ball inside this cavity which is which has a thick margin and the irregular inner wall should be considered as malignant. And this is an example of a malignant cavitating tumor with a mural nodule and air fluid level due to hemorrhage inside the tumor. And this is the CT scan of the same case showing a regular inner margin, the relative thickening of this particular wall compared to the rest of the margins of the tumor. Then in order to assess the local extent of the lesion, first the peripheral lung lesions, we have to know its relation to the chest wall. Then invasion of the chest wall by CT, there are only 2 sure signs, which are the presence of destructed rib and the presence of tumor tissue beyond the confinement or the lateral wall of the rib. And sometimes we can use the CT or the MRI to assess the patient during respiration and to look for the relation of the tumor to the chest wall in order to assess if it is being invaded or not. And this is an example of a bronchogenic carcinoma invading the chest wall with destruction of the rib and the tumor extending beyond the confinement of the rib into the chest wall muscles. Of course, you know that MRI is relatively more better for evaluation of chest wall invasion depending on the signal of the tumor. The tumor will show high signal in the T2 weighted image compared to the relatively low signal of the chest wall muscles. Then you can appreciate the extent of the tumor in the chest wall. One of the well-known bronchogenic carcinoma types is the Bankus tumor, where the tumor invades the apex of the lung and usually the adjacent ribs and chest wall. Then whenever we see a mass in the apex of the lung, we look carefully for the adjacent ribs for the possibility of rib destruction, and we may use or may get the help of CT to assess the exact size of the tumor and to show carefully that the tumor is eroding in the ribs and extending into the posterior chest wall. And you know that we have 3 important items here in the apex of the lung, which are the subclavian vein, the subclavian artery, and the brachial plexus roots. Of course, if this tumor has invaded the root of the neck, it may present with this classic syndrome, which is the Horner syndrome, in the form of ptosis, meiosis, and anhydrosis. But we usually need the help of MRI if we are going to operate on this patient in order to assess the tumor relationship to the brachial plexus, to the subclavian artery, and to the subclavian vein. And this relation can be obtained in the sagittal MR images in different pulse sequences in order to show the tumor and to show these structures if they are separate from the tumor or not. In cases of central masses, there usually some sort of bronchial obstruction leading to distal obstruction and collapse of the sublime lung. Then the CT has a little or lower resolution in separating the tumor from the adjacent lung collapse. And this is an example of a central bronchogenic carcinoma with distal lung collapse, and you cannot know where is the tumor mass and where is the consolidation. And this is very important whenever we are going to irradiate this patient or whenever we are planning to take a biopsy from this lesion, and we know that there is a good part of this lesion representing consolidation, not related to the tumor. But using MRI, we may be able to separate the tumor from the consolidation based on the signal behavior. You know that consolidation contains more fluid than the tumor. then in the T2 weighted images, the consolidation will appear brighter than the tumor itself, and we know this is the site of the tumor and this is consolidation. Also, we should assess the possibility of invasion of the mediastinal structures, like this bronchogenic carcinoma invading the left main pulmonary artery, and this bronchogenic carcinoma totally encasing the left main pulmonary artery. And here is a central lesion which is encasing and attenuating the left main pulmonary artery with metastatic mediastinal lymphadenopathy. And this tumor has invaded the mediastinal fat according to this T1 weighted MR image, and this is an enlarged lymph node, but the ascending aorta, the superior vena cava, and the descending aorta are not affected by the tumor. And by CT, we may be able to see one of the common associations with central bronchogenic carcinoma, which is invasion of the superior vena cava. This is the arch of the aorta, and here is the site of the superior vena cava, which is not seen as it is totally infiltrated by the tumor. And this is a lower lobe mass that has extended inside the left atrium. Of course, you know that PET scan has a good part in the diagnosis and the staging of lung cancer. And you know that this PET scan is the combination of positron emission tomography and the CT nowadays in order to give better anatomic resolution. And you know that the assessment of nodules or masses in the lung depend on what's known as the standard uptake value, or the SUV. And according to the literature, they consider the SUV, the maximum SUV of 2.5 as the threshold for malignancy. However, some of the reports said that an SUV maximum more than 3.6 may have a sensitivity of 81% and the sensitivity of 81% and the specificity of 94%. Then this is the coronal CT scan, and this is the coronal PET scan, and this is the fusion of both images. PET scan has a good role in characterization of pulmonary nodules and differentiation between the primary tumor and the related atelectasis, also in staging of nodal deposits of primary lung cancer, also in the preoperative planning or staging for the primary tumors, detection of extrathoracic metastatic deposits, and evaluation of postoperative local and distant tumor recurrence. Then the sensitivity, according to the literature, of diagnosis of pulmonary nodules as malignant by CT, which should be contrast enhanced, of course, reaches about 98% sensitivity, and the specificity is low, reaching 58%. And they sometimes use the difference between the density of the nodule in the pre-contrast scan and the density after injection of contrast, and they measure the attenuation value, and they say that if the attenuation value is more than 20 Hounsfield units, we may think of malignancy. This is the pulmonary nodule in a CT lung window, and this is the PET scan showing very hot uptake in the pulmonary nodule. And this is the benign hamartoma in the lung by mediastinal window and lung window, and you see that there is no significant uptake in this nodule. Now it's very important to say that pulmonary nodules, to be sure that this nodule is malignant, we usually want to have a histologic proof by imaging guided biopsies. But sometimes the nodule is not reachable by CT guided needle biopsy. For example, this lesion in a patient with colorectal carcinoma, this lesion may represent a vessel because it is very near to the hilum, but on the PET scan it shows very a strong uptake, and with an SU value of 10.9, then indicating that this is possibly a malignant nodule. And this nodule is not reachable, as I have mentioned, by CT-guided needle biopsy. Meanwhile, we have some fallacies in the PET scan, especially in areas with endemic infections and granulomas like TB and histoplasmosis. This is an example of a nodule located in the upper lobe, and this is the PET CT showing a strong uptake, and this nodule has been proved to be a tuberculoma. You know that there are some limitations for the PET scan considering the lesion size, especially if it is less than 7 millimeter in diameter, and also in cases of low tumor metabolic activity and in patients with hyperglycemia. And this is let us say, a mass in the lung with speculated margin, and the PET scan showed a very strong uptake, and the biopsy proved that this is nocardial. Then you know that in the CT scan there is no definite ability to separate the tumor from the peripheral consolidation in many cases, especially even if you inject contrast material. But with PET scan, it's easy to separate the tumor by very hot uptake and the peripheral consolidation, and also you can detect if there is lymph node metastasis. And this patient is prepared for radiotherapy of a lung cancer, and they want to locate the tumor separable from the consolidation, and this is the site of the tumor compared to the area of consolidation. Then one of the important roles of PET scan is to assess the mediastinal lymph nodes, particularly before surgery. Then if you see a peripheral lung nodule and you would like to assess the mediastinum for possible lymph node metastasis, or even to detect the site of the nodes for to be biopsied later on. You know that according to the literature, about 13% of normal-sized lymph nodes may contain tumor, and about 37% of nodes that are greater than 2 centimeter may not be malignant, may be reactive nodes. Then this is a pulmonary nodule, and it shows very hot uptake by PET scan, and there are mediastinal lymph nodes showing increased uptake. And this is also an example of a pulmonary nodule with this speculated margin in the upper lobe with 3 metastatic lymph nodes, and this one in particular was not apparent in the CT scan. And this is also a very small lymph node located here on the CT image, and it proved by PET scan to be of increased uptake, and after mediastinoscopy it is confirmed to be metastatic. On the opposite side, you can see multiple axillary nodes and also mediastinal nodes which show no uptake or very low uptake by PET scan, and these are reactive lymph nodes. One of the main tools for evaluation of lung cancer, whether in the form of nodule or mass, is to have the tissue diagnosis provided by the needle biopsy, guided by ultrasound or CT or MRI if available. Then the criteria of optimal procedure is the presence of a peripherally located lesion, and the lesion may be, if it is more than 2 centimeter in diameter and there is a very short track between the lesion and the chest wall, and if you have a perpendicular pathway, this is good, but you should avoid if there is no obstacles like bone or major vessel or emphysematous bull. And many times, as many as 30% of the cases may develop a small amount of pneumothorax after the procedure, and this pneumothorax is self-limited and it resolves spontaneously. But about 6% of the cases may develop pneumothorax that is rapidly accumulating and needs some intervention. Then pulmonary hemorrhage is usually seen in patients with low coagulation profile, and if you pass a long way through the lung to reach a lesion, especially in the mediastinum, then after introduction of the lesion you got a patch of or opacity in the lung along the leader tract representing a pulmonary hemorrhage, And this, you should say to the patient that in the coming 2 days, your cuff will be stained by blood. Then imaging of the distant tumor spread. You know that the most common two sites for spread of the lung cancer are the suprarenal glands and the brain. This is a huge bronchogenic carcinoma invading the superior vena cava with huge bilateral adrenal metastasis. And this is a brain of a patient presenting first by brain deposits, and searching for the primary, it was in the chest, and this is a common scenario in the clinical practice. Also in detection of metastatic spread elsewhere in the body, you may use the whole body PET CT scan, and this is an example of a small metastatic deposit in the upper part in the upper dorsal vertebra, and this is a bronchogenic carcinoma with some metastatic deposits in the spine as well as in the sacrum, as shown by the PET and PET CT. Then, according to the literature, the TNM classification is used for staging of the bronchogenic carcinoma, and stage 1 refers to as a lesion which is less than 3 centimeters in diameter and not invading the main bronchi. This is an example, which is a nodule with a speculated margin. And if the tumor is larger than 3 centimeters with invasion of the pleura or invasion of the bronchi at a distance more than 2 centimeters from the carina or associated with local atelectasis, and this is stage 2. Stage 3, the tumor of any size with invasion of the pleura, invasion of the chest wall, the diaphragm, the pericardium, or the bronchi at a distance less than 2 centimeters from the carina or maybe associated with atelectasis of the whole lung. And the stage 4, a tumor of any size invading the heart, the mediastinum, the spine, the major vessels, or in the associated with malignant pleural effusion. Then lymph node metastasis. If there is no lymph nodes, this is the best for the patient. And one is ipsilateral nodes, which are peribronchial and hilar. And according to the literature, these patients are still candidate for surgery. In stage 2, the ipsilateral nodes, but at more sites, especially in the subcarinal and mediastinal sites, and these patients, according to the literature, will not benefit from surgery. The contralateral nodes exclude the possibility for surgery for these patients, according to the literature, and the contralateral nodes in the hilum, the mediastinum, or the supraclavicular area. And thank you very much.